Hello, everybody. Good evening, good afternoon, good morning, wherever you are from. Welcome to NDQF's last webinar of the year 2020. My name is Rajiv Acharya. I work for the Population Council. You all know about NDQF because we have been coming to listen to these webinars again and again, and we are bring to you different types of topics. Today we have a very different topic that very few webinars or seminars would have happened in the global event. Is that just because I was born dead, do I not matter as a title? It's about the stillbirth data. So let me say that we will today start with a small Mentimeter quiz. It must be on your chat. Can you put the link in the chat, please? So you can see a link in your chat, and please try to answer the question as per whatever you know about this issue. We have only 2 questions, so count for the first question starts now. Okay, 10 minutes more, 10 seconds more. Tisha, go to the next question, please. Please answer this question. Come on, we have only 10 seconds more. Okay. Time up. What's the final result, Tisha? Okay, so this is the so most people say 24 per 1,000 births is the rate of stillborn borns, and the next one is almost equal whether you know somebody who had a stillborn. We have an exciting panel today, and it will be moderated by Dr. Sarita Naya, who is a social scientist at the ICMR National Institute of Medical Statistics. She has done her PhD from IIPS Mumbai, and her interest area in her work areas include reproductive health, causes of death, and women's issues. Over to you, Sarita. Before I make it, I'm transfer the control to you. Just to say that everybody will be muted, and any question, anytime, please put it on the chat, and we will take up the questions at the end of the session. Thank you. Over to you, Sarita.
Thank you, Dr. Rajiv. And it was good to start with the quiz. So I'm sure everyone is stimulated for the discussion and to hear from our eminent panelists. The loss of baby due to stillbirth in the final stages of pregnancy is a misfortune for mothers, fathers, and families across the world. Significant progress has been made during the last 2 decades, but there are still an estimated 2.6 million stillbirths every year. Most of these losses are preventable by counting the number of stillbirths, gathering information on where and why these deaths occurred, and also by trying to understand the underlying contributing causes and avoidable factors. Healthcare providers, program managers, administrators, and policymakers can help to prevent future deaths and grief for parents and improve the quality of care provided throughout the health system. We are honored to have amongst us eminent panelists who will enlighten us on the burden of stillbirth, the risk factors and causes, and also highlight data quality issues around it. So the first two panelists will enlighten on the burden of stillbirth, the risk factors and causes, and also highlight data quality issues and possible solutions around these, followed by sharing of individual national and international experiences from our experts, and then our eminent panelists would be discussing on it. Before I pass the mic to Dr. Rakhi Dandona, who is our the first speaker, I would like to introduce her. It's an honor to introduce Dr. Rakhi, who is a professor at the Public Health Foundation of India and professor of Health Metrics Sciences at the Institute of Health Metrics and Evaluation, University of Washington, Seattle. Professor Dandona has over 2 decades of experience in gathering empirical evidence on disease burden and risk factor distribution at the population level through epidemiological studies and the health system studies in India. Dr. Dandona has been involved with mortality estimation over a decade at the population level using verbal autopsy. Dr. Dandona has specific interest in understanding and underreporting of the stillbirths and neonatal deaths, and her team's recent research has contributed to building evidence for stillbirths in India. So without much ado, I would request Dr. Rakhi Dandona to kindly deliver her talk.
Thank you so much, Dr. Sarita, for that introduction and the opportunity to talk today. I'm sharing my screen. Can you confirm if it...
Yes, ma'am, we can view your screen.
Is this visible, the slides?
Yeah. Yes. Thank you.
Perfect. Thank you so much. I can't see them now. I can, yeah. As Rajiv said, this is a very unusual topic for a webinar, but we're very happy to be part of this webinar today, bringing visibility to stillbirths in India. I will talk about, what we understand of the burden of stillbirths at population level in India. Stillbirths, for those who are not very familiar with what it means, it's a birth of a baby who at birth does not cry, does not breathe, and does not move. These are typically babies born between 22 weeks to full term. So what happens is, instead of having a live birth at the end of pregnancy, the parents have a stillborn baby. The grief of stillbirth is actually not comparable to any other form of grief that we know of. And that's something that's not very difficult to understand, but it's something that is really not talked about on a usual basis. And unfortunately, events with stillbirth are not rare. And that's what the recent UN report tells us. Nearly 2 million babies are still born worldwide annually, which is 1 in 72 babies being stillborn. 6 countries in the world have the highest numbers, and India is one of those countries. I will quickly take you through the various issues within the mortality audit cycle in terms of data that we understand for India today. This is the SRS estimate for stillbirths in India from 2000 to 2019. 8 stillbirths to 4 stillbirths per 1,000 births. However, the recent UN report puts it as 30 in 2000 to about 14 now in 2019. So there's already a difference of 3.5 times in the estimates that we have available from SRS, which is the official estimate in India, and from the UN reports. Now, important to remember, this UN report is based on data from India, a variety of data, including the surveys. The India Newborn Action Plan, which was released in 2014, interestingly has set a target of less than 10 stillbirths per 1,000 births by 2030, and they assumed 22 stillbirths in 2009 to set this target. They had also used modeling approach because there is underreporting of stillbirths in India. Importantly, the drop for stillbirths from 30 to 14 is about 53%. So we've made a lot of difference, but there is lots more to do. But 74,000 births in India happen every day. So what does it mean in real terms? So of these 74,000 births every day, based on this rate, at least 1,000 parents do not get to take a live baby home after the delivery. So in addition to the significant underreporting in stillbirths in the SRS, we looked at CRES. About 64,000 stillbirths were reported in 2018 in CRES. And if you look at the rate of 14 per 1,000, which means less than 50% of the stillbirths actually were counted in CRES. This is as compared with 90% of all live births. So it clearly highlights the difference in how we look at stillbirths in terms of reporting and how we look at live births. Why is this reporting and underreporting that important? Let's assume this to be all stillbirth babies born in a day. So many of them are not registered in CRES, and then the SRS does not capture many of them. And that's what we are left with. Then we assume that the burden of stillbirths is only what we see, because this is the only burden that we capture. Therefore, counting of stillbirths and reporting of stillbirths is very important, one of the first basic and very simple steps to start understanding the burden of stillbirths in India. After stillbirths, understanding the burden, we need to understand why some babies are born stillborn. What goes wrong with them? NFHS is one of our largest surveys which captures the RM&CH indicators and based on which policy and programs are developed for India. Unfortunately, NFHS surveys do not document pregnancy details if the last pregnancy was stillborn. So we have no understanding at that large national level which babies are born stillborn and why. Then the other option to understand what goes wrong are the audits that are meant to happen for any perinatal mortality and maternal mortality at facilities. Now, we all are aware of the accountability issues with this because the nature of these audits is very punitive because it's about what facility did not do to save the baby, and the actions are punitive in nature. The actions are not meant to understand what went wrong so that it doesn't go wrong tomorrow. So what happens typically is stillbirths also sometimes get over-reported in facility data because the neonatal deaths are reported as stillbirths. And the logic is very simple. Because the baby was born dead, we couldn't have done anything. And that's where the problem starts. Because the problem is we could have saved at least 40% of these babies. We do have some understanding of the type of stillbirths classification if you classify them as antepartum and intrapartum through verbal autopsies, to the work that we've done in Bihar and UP. But it also highlights how difficult it is to understand in the absence of clinical data. If we take the last movement of the mother, when did the mother feel the baby last, as the criteria to understand fresh or not fresh stillbirth, it's about 50% of the births were antepartum and about 40% were fresh or intrapartum. However, if you take the appearance of the baby as the main indicator, this 50% changes to 18%. So clearly, we really don't understand the classification of stillbirths yet because in the absence of clinical data, verbal autopsies can inform us only so much. Our work from Bihar and UP again has highlighted the risk factors for stillbirths, and I want to discuss these two still factors. This one, deferred deliveries. We found this very interesting that there were some women who went to the facility saying that they were ready for delivery, but they were sent back from the facility because there was time for delivery. And many of these women, when they returned for delivery another day, the baby was already dead. So we've called them deferred deliveries. This was not highlighted earlier, and we've kind of started to highlight that at population level. The other interesting part was referred deliveries. If you look at all births in Bihar, about 6% of all births were referred. But if you look at births which resulted in stillbirths, about 30% of them were referred. And reading the verbal autopsies, it's very clear these mothers are sent from one facility to another facility to another facility, and that time loss between going from one place to another, they lose the baby. So clearly important understandings here that have practical relevance for implementation. I do want to bring your attention to this one. Many of the women actually had to go to another facility because the health providers refused to deliver a stillborn baby. These two also have implications related to COVID because the understanding is that deferred and referred deliveries would have gone up because of COVID-related lockdown and other issues. There is evidence from elsewhere that this could be a possibility, but we do not fully understand that for India yet. In terms of interventions and risk factors, what's important to also note is that these risk factors and interventions for stillbirth are actually not very different than those for early neonatal deaths. What's different is our mindset. What's different is if the baby is born dead, we really don't want to do much about it because we assume nothing much can be done about it. For India, we really do not have much data on what happens with the parents. What happens when a baby is born? Is the baby shown to the patient? Is the baby held in arms? How are the last rites done for these babies? We fully do not understand what's going on. We do have some understanding from our work, but it's very basic in nature for us to do much about it. But the only thing that stands out across all the verbal autopsies that we've read, that most women said, the only thing that most people ended up telling them was, get pregnant again so that they can forget this baby. Clearly, that's not the solution, and one of the parents on the panel will talk to us about it. And the parent involvement can actually make a lot of difference in bringing visibility and making sure we have enough data to make sure another baby is not stillborn tomorrow. So to end the presentation, I do want to bring about, just to summarize it, we need to understand the magnitude better. And for that, we simply need to start counting and reporting these babies. This will happen if we start talking about these babies within the health system, but also at societal level. There's a taboo about talking about these babies, but no, we need to talk about these babies, count these babies if this needs to change tomorrow. We need more data on risk factors and causes specific to India that we can use to intervene. And we need to understand the grief better so we know how to help these parents to cope with the situation that they have been dealt with. Thank you.
Thank you, Professor Rakhi, for clearly highlighting the need for data around stillbirths and also the socio-cultural practices around, silencing of this whole entire event of it. I'm sure audience also have many questions which we have parked it, and then probably towards the end of it, after the discussion takes place, we can have a look at it. Now, I invite Dr. Neelam, Professor Neelam Agrawal, to speak about the risk factors and causes of stillbirth. Professor Neelam Agrawal is a professor at the Department of Obstetrics and Gynecology at the Postgraduate Institute of Medical Education and Research, Chandigarh. She is the nodal officer for WHO's year Stillbirth Review. She is currently the president of the Indian Menopause Society and has held many positions in the past. Her areas of interest include high-risk pregnancy, perinatal health, and menopausal health. May I invite Professor Agrawal to kindly highlight the issue and talk about the data issues around the risk factors to understand the causes of stillbirth?
Unmuted. Hello, can you hear me?
Yes, Professor Agrawal, we can hear you.
Yeah, I don't think you can see me because there is some issue with this Apple. Can you see my slides?
or not yet?
So I have,
Radhika, can you please help?
Radhika, you put on my slides then. मैंने मेल की है राजीव आचार्य की मेल पे. So I'll be talking about the risk factors and the causes of stillbirths. So Rakhi has made my job quite easy, right? So well begun is half done. So I'll be talking about the risk factors and the causes of stillbirths. Radhika, can you put on my slides, please?
Just a sec, ma'am. We are getting your slides.
Okay. So I'll put my slides off, right?
Ma'am, we will share the slides.
Yeah. So you only have to then navigate with them, right?
Yes, ma'am.
Radhika, can you allow me to share the screen?
Radhika, I had sent in the morning to Rajiv's mail. Hello?
Yes, ma'am. We have the slides. Rajiv is sharing.
Yeah. So Rakhi has talked about the numbers, but just simply being counted is not enough. Because till we know what is the problem, we will not be able to prevent the stillbirths, right? Numbers are important, very important. Next slide, please. Yeah.
Radhika, is it okay? Can you see the screen?
Yeah, I can see the screen. So as I said, simple counting is not enough for making the preventive strategies, and data we need on core indicators of quality of care and availability of care, which is available to the pregnant mothers, so that we can plan the strategies, monitor them, and improve the continuous efforts being made to prevent stillbirths. Next slide, please. Next. Yeah. So setting specific goals is the first step towards any improvement. So first specific goal was to make the numbers understood. So after counting the numbers, now we need to know the constituents of framework to understand stillbirths better. So for this, we need to know what kind of care is available and what is the quality of care available and the circumstances around stillbirths with associated conditions prevailing at that times and the underlying causes. These associated conditions may involve the risk factors as well as some other associated illnesses and other modifiable factors around the time of birth of these stillborn babies. Next, please. Next, yeah. So please keep clicking. So this is a study which showed that risk factors. This is a study from India, risk factors and how much a responsive health system can prevent. So here the conclusion made was that a proactive health system with accessible, timely, and quality obstetrical care will definitely make a difference. And world over, it is the same challenge, not only in low middle income countries. This BMC pregnancy childbirth article shows us all the issues in data collection for stillbirths. And the third study is from Africa. All these show there are a lot of modifiable factors in the low income countries. Next, please. Next slide, please. Yeah, risk factors. In cases of stillborns, there is a considerable overlap between risk factors and the causes. Causes are the clinical conditions which are responsible for the stillbirths, whereas risk factors are the common factors which increase the chances of having a stillbirth. And they are most important when we consider the continuum of care from pregnancy to the perinatal period. And data on stillbirths emphasize that stillbirths, they represent the earlier phases of pregnancy, and care given in that period benefits both maternal health as well as the child health, including prevention of the stillborn. Next. Are risk factors same in all? No, like this fauna and flora of every region is different. Similarly, in HMICs and LMICs, click please. Next. The risk factors are different. For example, in high income countries, main risk factors are advanced maternal age, high BMI, and smoking. Whereas in low middle income country groups, it is mostly the availability of care, quality of care, and accessibility to care. So modifiable factors are much more in LMICs rather than HMICs. These need to be considered in the region context, specific context, so that to have preventive strategies. Next, please. So these are the determinants of stillbirth. On the right side are the risk factors, and on the left side is the preventive measures, and in the center is the causes of stillbirths. So risk factors actually do not directly cause a stillborn, but they increase the chances of stillborn. For example, care not accessed, care not available, care not a quality care. So these are the factors, and socio-determinant epidemiological factors of the maternal community. So all these are risk factors for the stillborn, whereas direct factors include infections, intrapartum factors, intrapartum care, fetal factors, placental and cord, and maternal factors. Next, please. So these risk factors, modifiable factors, are the missed opportunities actually. Those, if we can tackle, can prevent the stillbirths. So these factors can be assessed either by 3 delays model or on the patient provider system model, where delay 1 is delay in seeking care, which is on the part of family or patient. Second is delay in reaching the healthcare facility, which is maybe logistically or administration related. And then delay in receiving care health at the healthcare facility, which is provider related, and these are mostly modifiable. Next, please. Next slide, please. So there are multiple challenges in, first of all, getting availability of the data collection. First of all is the incomplete medical records. No, not complete. Medical records are grossly incomplete. Sometimes there is no period of gestation mentioned, baby weight mentioned, sex of the baby, or anything else, any maternal condition, fetal condition, nothing is mentioned. And sometimes the details are inaccurate. As Rakhi said, there may be, because of the punitive actions, those patients, those women, they are shown to be attending the hospital with no fetal heart, so that the persons present there are not punished. So similarly, fetal movements are not checked, and it is not mentioned whether this was a stillbirth before labor started or after labor started. So we cannot assess whether it is the fault in the antepartum care or there is a lacunae of the intrapartum care. Next. And then whether it is a fresh stillbirth. Previously we used to say fresh or the macerated stillbirth. These days we call it antepartum or intrapartum stillbirth. So this means whether if the baby died, fetus died before start of labor, that was antepartum stillbirth, or a macerated stillborn. But if it occurs during labor, then it is a fresh stillborn or intrapartum stillbirth. So fresh stillbirth means lacunae at the level of intrapartum care and macerated in the antenatal care. However, such data is not easily available, not readily available. That is why we are not able to assess which services to improve. Next. And challenges for data availability could be adequate workforce, adequately skilled staff being not there, and then they may not be having adequate knowledge about stillbirths. Then more important is the social factors and the attitude. Let's ask ourselves, everybody, do we react for a stillborn the same way as for the maternal mortality? Obviously no, because most of the people think that there is another chance for a mother to have a baby, but the maternal chance is only once. So, but these challenges for data availability and completeness of data, they are mostly similar to those with neonatal mortality. Next, so if we improve at the stillbirth level only, neonatal mortality will also improve. So it will be a triple investment in the stillborns, in the neonatal care, and in the maternal health care. So this has been already shown by Rakhi. These are the preventive actions starting from the preconceptional care, then during the pregnancy, during the labor, continuing in the postnatal care, and they are the same as with the neonatal care, and these factors are the same which will prevent stillbirth, and they will also reduce the neonatal mortality. Next. So this is a prevention bundle by Stillbirth Center of Research and Excellence from Australia. They have also given 5 points: quitting smoking for the baby, then taking care of the fetal growth during pregnancy. That is, they have to be very, very conscious about the fetal growth, because fetal growth reduction is one of the major causes of stillbirth. Then movements, making the women aware about their fetal movements, because that also is an important factor. Then sleeping on the side rather than on the back. And then next is start timing the delivery, because if there is any high risk factor, induce well within time before we have the stillbirth, right? So next, this will go a long way in prevention of stillbirths. Next, please. So these were the causes and the risk factors. So just in a nutshell, being counted is essential but not sufficient for planning, monitoring, and improving efforts to prevent stillbirths. Locally relevant data to understand the risk factors and causes is urgently needed in India, especially. Clinicians and nurses, they need to document details for each pregnancy in clinical records and provide relevant and appropriate quality of care. And clinical data availability across the continuum of care is needed to support perinatal health, including stillbirths. And for this, mindset, attitude needs to be changed, nothing else. Thank you. And I'm sorry for the video. I don't know why this Apple did not allow me to access my video, but
Thank you so much, Professor Agrawal. I mean, it's been really, really important, and a presentation that highlighted the, the missed opportunities and also the modifiable factors which could at least save few of the babies, or maybe many of the babies, and also detailing about the unavailability of data, which Dr. Rakhi also highlighted. So I think the emphasis on data, the need for data, and the voices to be heard is important for addressing this issue. As we move on, now we have with us Seema. Seema ji, I'm just trying to, Miss Seema Sindhwani Anand, and she is, bereaved parent. So we would be hearing from her about, what she has gone through while having a stillbirth baby. So we know that national and regional estimates of numbers and causes of death are useful, but they do not tell the whole story. So examination of individual cases gives us the opportunity to identify the reasons why these deaths occur and provides us the opportunity to learn about what needs to be done to prevent similar deaths in future. So let me introduce Seema ji. Seema ji has done her MBA in Human Resources. She's a senior sub-editor with the Amar Ujala since 2010. And she had a baby girl, who was born stillbirth last year. Seema ji, and I would also, say that probably I would be speaking in Hindi and English so that, it becomes a little easy for us to converse. And, when we talk something which is emotional, it's always good to have the conversation going in our local language. So for others who who cannot understand Hindi, we would be typing that in the chat box. So then you would get an overview about what Seema ji is trying to tell us. And Seema ji, thank you so much for actually accepting our invitation and being here on this show. Thank you so much. I'm sorry.
हेलो
या हाय। तो हमारे साथ आज इस वेबिनार में अपने स्टिलबॉर्न बेबी के बारे में कुछ बातें सबके साथ शेयर करने के लिए हम आपके बहुत आभारी हैं। क्या मैं आपसे कुछ सवाल पूछ सकती हूँ?
श्योर।
थैंक यू सो मच। सीमा जी, पिछले साल आपकी बेबी गर्ल स्टिलबॉर्न पैदा हुई थी। आप इसके बारे में हमसे क्या कुछ शेयर करना चाहेंगी?
बिल्कुल। एक्चुअली वो मुझे लगता है कि बच सकती थी। मेरे लीवर में थोड़ी प्रॉब्लम थी, मेरे एंजाइम्स लगातार बढ़ रहे थे, तो मेरा पीजीआई से ही ट्रीटमेंट चल रहा था, उधर मतलब लीवर डिपार्टमेंट में, हेपेटोलॉजी में, और इधर गायनी में। तो मेरे लीवर वाले जो डॉक्टर हैं, डॉक्टर आरका और डॉक्टर वीरेंद्र सिंह, दोनों ही बहुत सपोर्टिव थे, दोनों ही बहुत मतलब उन्होंने बहुत मतलब इवन मतलब मुझे वेट नहीं करने देते थे कि मतलब तुम एक तो तुम्हें वैसे मतलब लीवर की प्रॉब्लम है तो तुम वेट मत किया करो, और तुम मतलब नंबर बस सिर्फ एंट्री करवा लिया करो और आ जाया करो अंदर, मतलब इतना ज्यादा। और दोनों डॉक्टर्स ने, कभी कोई डॉक्टर नंबर नहीं देता अपना, उन्होंने दोनों ने अपने नंबर तक दिए हुए थे, मेरे से शेयर किए हुए थे। इवन एक बार मैंने अपनी गायनी वाली डॉक्टर से उनकी बात भी करवाई थी, तो उनका ये कहना था कि जब आप, क्योंकि देखो अगर दूसरे तीसरे चौथे महीने में अगर कुछ मिस कैरेज हो जाता है तो वो भी बहुत पेनफुल होता है, पर जब अगर आप 8 मंथ क्रॉस कर जाते हो, 8 मंथ क्रॉस करने का मतलब है कि आपको लगता है कि बस अब सब जो डिफिकल्टीज थी, जो मतलब प्रॉब्लम्स थी, मतलब सब खत्म हो गई हैं, मतलब अब 9 मंथ में आप एंटर कर गए हो, तो अब तो मतलब बच्चा ही घर आएगा। मतलब जब भी आप जाओगे, सॉरी,
आई एम सो सॉरी टू ब्रिंग दिस इशू अगेन।
मतलब जब आप घर से जाओगे तो आप मतलब बेबी को लेके आओगे।
आई एम सो सॉरी, मे बी आप थोड़ा I mean, it is so important.
मतलब मैंने हर बार, मैंने जब मुझे 9th मंथ स्टार्ट हुआ तो मैंने अपने डॉक्टर से बोला कि मुझे डॉक्टर ने बोला है कि 9th मंथ जो है वो बहुत क्रूशियल होता है बेबी के लिए। बेबी के लिए ऐसा होता है कि जैसे वो उसको पॉइजन में रखा हुआ है, मतलब इतना तक मैंने बोला कि मैंने कहा 9th मंथ स्टार्ट हो गया है तो आप मेरा सी सेक्शन कर दो। तो हर फ्राइडे को मैं जाती थी ऑफिस से छुट्टी लेनी, और मैंने मतलब वहां जाना। इवन कई बार मैं संडे को चली जाती थी ऑफिस कि मुझे संडे के ऑफ की बजाय मुझे फ्राइडे को मेरा ऑफ मतलब एडजस्ट कर दो। तो मतलब इवन हमारे एडिटर ने भी कभी ऑब्जेक्शन नहीं किया, वो बोलते ठीक है आपको जैसे ठीक लगे आप करो। तो मतलब मैं फ्राइडे को गई, मैंने उनको बोला कि आप सी सेक्शन कर दो, कहते नहीं अभी थोड़ा सा टाइम है, 37 वीक हो लें। तो मुझे लगा, मैंने कहा चलो ठीक है, उनको ज्यादा पता है। फिर मैं 8 नवंबर को गई, तब 8.5 महीने कंप्लीट हो चुके थे, और तब मैंने उनको बोला कि मैंने कहा कि आप मेरा सी सेक्शन कर दो, मुझे लीवर वाले डॉक्टर कह रहे हैं कि 8 मंथ कंप्लीट हो चुके हैं, 8 मंथ के बाद बच्चे के जो बॉडी पार्ट्स बनने होते हैं सब बन चुके होते हैं, तो अब तो 8.5 महीने हो गए हैं। तो वो बोलते हैं कि अच्छा आप 1 वीक और रुक जाओ। तो मैंने उनको बहुत कहा कि मतलब आप मुझे चाहे एडमिट कर लो, आप मुझे चाहे रख लो, मतलब यहाँ पे अगर आप नहीं, मतलब अभी आपको लगता है। और मैंने ये भी बोला, मैंने कहा बचना होता है तो मैं 7 मंथ के बच्चों को भी आप बचा लेते हो ना। तो मैंने कहा अब तो 8.5 महीने हो गए हैं। तो उन्होंने बोला अच्छा ठीक है, आप नेक्स्ट वीक आओगे तो आप पूरा वो करके आना कि हम आपको एडमिट कर लेंगे। तो मैं वापस आ गई, मैं 2 बजे तक वहां थी, मेरा एनएसटी हुआ, सब अल्ट्रासाउंड हुआ, बेबी की मूवमेंट थी, सब कुछ था, अच्छे से बेबी घूम रहा था, मतलब एनएसटी भी पूरा, जैसे जो उसकी धड़कन थी सब कुछ ठीक था। शाम को मैं 5 बजे, हम चंडीगढ़ के नियर बाय ही है जीरकपुर, वहां रहते हैं, तो 5 बजे के करीब, 4:30 बजे के करीब मैं घर पहुंची। तो मैंने कपड़े वपड़े चेंज नहीं किए, मुझे लगा कि सुबह से थकी हुई हूँ, तो मैंने एक ऑरेंज खाया और सो गई। उसके बाद हमारे मतलब फैमिली, कुछ फ्रेंड्स आए हुए थे, तो मतलब मैंने उनको मिली भी सही, मिल के फिर मैं सो गई। रात को 3 बजे मुझे एकदम से पेन हुआ। उसके बाद मेरे हस्बैंड ने एम्बुलेंस बुलाई, तो एम्बुलेंस वाले बोले कि नहीं आपका पंजाब है, तो ये चंडीगढ़ का नंबर है। तो फिर मेरी मदर इन लॉ ने बोला कि ऐसे क्या टाइम वेस्ट करना, तो वो ऊपर हमारे भैया हैं एक, तो उनके पास गए, तो वो उन्होंने भी मुझे 20 या 25 मिनट में पीजीआई पहुंचा दिया। जैसे मैं पहुंची तो उन्होंने बोला कि बस अभी आपका को वो करना पड़ेगा कि बिल्कुल बस बेबी मतलब अ, बस आपकी डिलीवरी करनी होगी अभी। तो जैसे लेके गए, तो फिर एक डॉक्टर ने कहा कि मुझे एक बार चेक करने दो कि बच्चे की हार्ट बीट है या नहीं है। तो जब उन्होंने हार्ट बीट चेक की तो बोलते कि नहीं, बच्चे की हार्ट बीट नहीं है। तो उसके बाद मतलब वो इतना कितना पेनफुल था, कितना पेनफुल था। उसके बाद एक डॉक्टर थी, जूनियर डॉक्टर ही थी, पर मैंने उनका ऐसे हाथ पकड़ा कि बहुत, जैसे बंदा पेन में होता है, उन्होंने ऐसे हाथ झटक दिया मेरा कि मतलब अरे मुझे मत छुओ। मतलब कितना इंसान उस समय पेन में होता है, और उस समय मतलब मैं बता नहीं सकती कि क्या वो था, बस मतलब मेरा ऐसा मन कर रहा था सच में कि मैं उसका गला दबा दूं, मतलब इतना बुरा लगा मुझे। उसके बाद फिर नेक्स्ट डे मॉर्निंग में नॉर्मल डिलीवरी हुई 9 नवंबर को। और फिर उन्होंने मुझे दिया, हालांकि उन्होंने बोला कि हमने आज तक कभी इस तरह से स्टिल बर्थ जो होते हैं तो उनको कभी देते नहीं है मदर को। उन्होंने मुझे दिया, मैंने 15-20 मिनट अपने ऊपर लिटा के रखा उस बच्ची को, मतलब ये सोच के शायद उसकी पता नहीं धड़कन वापस आ जाए। मतलब वो इतनी वो स्वीट थी ना, मतलब 3.25 किलो की थी। और आप सोचो, मतलब दोपहर को 2 बजे तक सब कुछ ठीक था, और फिर मतलब पीजीआई में मैं चेक करा के आई, सब कुछ उनके सामने था, उनको सब कुछ ठीक लग रहा था, उन्होंने मुझे वापस भेज दिया। और 5 बजे तक तो मतलब मैं पहुंची। उसके बाद 7-8 बजे तक मुझे, जब तक मैं जाग रही थी, मुझे फील भी हुआ, उसकी धड़कन भी महसूस हुई, उसका मूवमेंट भी महसूस हुआ। उसके बाद रात के 3 बजे तक एकदम से ऐसा क्या हो गया कि मतलब सब कुछ खत्म हो गया।
I'm really sorry सीमा जी। I mean ये सब हमें बताने में जो आपको दुखद अनुभव महसूस हुआ होगा, उसके लिए हम आपसे माफी चाहते हैं। जो आपके साथ हुआ, या मैं I'm really sorry, I mean all of us, वो जो आपके साथ हुआ है वो दूसरों के साथ ना हो।
बिल्कुल, इसीलिए मैंने मुझे जब डॉक्टर भारती ने बोला, हालांकि डॉक्टर भारती बहुत अच्छी है, मतलब डॉक्टर भारती ने मतलब इसमें से निकलने में मेरी इतनी हेल्प की ना। कहाँ उस एक डॉक्टर ने मेरा हाथ झटक दिया था, कहाँ डॉक्टर भारती ने मतलब एक तरह से मुझे कंधा दिया कि मतलब तुम रात के 12 बजे भी अगर मुझे फोन करोगी ना, कभी ऐसा नहीं होगा कि तुम्हारा कॉल अटेंड नहीं करूंगी, अगर मैं बिजी भी होंगी तो कॉल बैक करूंगी। और वाकई में उन्होंने आज तक कभी भी मतलब मैं रात को भी अगर फोन कर देती हूँ ना, तो मतलब फोन अटेंड करती हैं वो। और मतलब बिल्कुल ऐसे मतलब उनको ये लगता है कि पता नहीं क्यों मतलब इतनी अटैच हो गई है ना वो मेरे से, कि मतलब जैसे एक मतलब बहन की तरह। मतलब उनको ये नहीं लगता कि ये पेशेंट है और मैं डॉक्टर हूँ। तो मतलब
That
एक
is very
होते
good.
ना।
Yeah, मैं I mean समझ सकती हूँ. I mean there are really good. I mean that was a good gesture by the doctor कि हाँ आपको उन्होंने सांत्वना दी. मैं ये जानना चाहूंगी कि आपकी तरफ से कुछ सुझाव है जो आप देना चाहेंगे.
हाँ बिल्कुल, मुझे ऐसा लगता है कि जैसे अगर आप 7 मंथ के बच्चे को बचा सकते हो, तो वो तो मेरी तो 8.5 महीने की बच्ची थी ना। तो अगर आप चाहते, अगर आपको पता है, आपको इतना बताया जा रहा है कि पेशेंट आपको ये बता रहा है कि मेरे लीवर वाले डॉक्टर ने ये बोला है कि 9th मंथ बहुत बच्चे के लिए ऐसे होता है कि जैसे मतलब एक तरह से पॉइजन के बीच में वो पड़ा है, तो मतलब आप सी सेक्शन करवा लो। अगर मैं खुद कह रही हूँ कि मेरा सी सेक्शन कर दो, तो 37 वीक की ठीक है आपकी कोई गाइडलाइंस हैं, पर अब भी तो वो गई ना बच्ची, वो बच सकती थी ना। और अगर 7 मंथ के बच्चे को आप बचा सकते हो, तो 8.5 महीने के बच्चे को क्यों नहीं बचा सकते? तो अगर अगर उस समय मतलब वो डॉक्टर अगर मेरी सुन लेते, तो आज 1 साल 1 महीने और 8 दिन की होती मेरी बच्ची।
ओके, थैंक यू सीमा जी. आई मीन एंड एक लास्ट सवाल जो पूछना चाहूंगी, अगर आप जल्दी से उसका भी सवाल का उत्तर दे दें तो सही में. तो जैसे आपने कहा कि डॉक्टर ने आपकी मदद की थी आपको इस हादसे से उभरने में, और आपकी फैमिली का सपोर्ट भी था, कैसा था?
बिल्कुल, बिल्कुल, बिल्कुल। मतलब मैं ऐसे बोलती थी ना कि उसकी बजाय मैं चली जाती और मतलब बच्ची बच जाती। तो मतलब मेरी मदर इन लॉ, मेरे मेरे हस्बैंड ये बोलते थे कि बच्चा तो हम कहीं से भी ले आएंगे, अडॉप्ट कर लेंगे, पर तुम्हें हम कहाँ से लाते? मतलब उन लोगों ने मतलब मेरी इतनी इससे उभरने में मतलब इतनी हेल्प की ना।
That's nice. I mean, बहुत अच्छा हुआ. I mean, sorry that the event was really depressing and वो नहीं था, but at least family support was there and the doctor who supported was also great. So that way, I hope that women do get these support which keep them going. Thank you सीमा जी. ये
मतलब
आपके लिए
आप
आसान
आप
नहीं था.
बिलीव नहीं करोगे, मतलब जब मेरे लीवर में एंजाइम्स बढ़े हुए थे, मैं ऑफिस में एक प्लास्टिक का हाथ लेके जाती थी, जिससे मतलब मैं ऐसे ऐसे करती थी और मेरे कलीग्स मतलब मजाक उड़ाते थे मेरा। मतलब इतनी मुश्किल से मतलब मैंने वो ना एक एक दिन करके काटा कि बस अब थोड़ा सा रह गया है, बस अब बॉयल खाना भी खाया, मतलब जो डॉक्टर ने मुझे बोला मतलब सब वो किया कि मतलब अब 8.5 महीने तो हो गए, बस अब तो 10-12 दिन की बात है, अब तो बस आ ही जाना है। और सब बोलते थे कि तुमने इतना सब्र किया ना, तो सब्र का फल बहुत मीठा होता है।
I'm
मतलब
sorry कि
बहुत
आप.
पेनफुल होता है।
नहीं नहीं सही. I'm sorry कि आपको ये सब कुछ bear करना पड़ा. But I hope you have the strength to go through this. I'm so sorry. And I hope that आपके जैसे parents इसके बारे में बात करेंगे तो ही stillbirths के लिए action लेने के लिए government और clinicians serious होंगे. So thank you so much for being part of this discussion. Now we would go to the speaker who is going to share with us the international perspectives of bereaved parents and talk about the stillbirths. So I invite Dr. Susan to kindly, I'm sorry, yeah. Dr. Susan Hopkins Leisure, who is the chair of International Stillbirth Alliance, to kindly throw light on this issue. Thank you so much. Dr. Susan, we can't hear you.
Hi,
All
Zan.
right.
Could you
Yes.
try?
Now, are you all set?
Yes.
Okay. And you can see my slides?
We can see your slides.
Perfect. Thank you so much for this opportunity, and especially to Seema for her courage in sharing the story of her precious baby. One of the biggest stumbling blocks to stillbirth prevention, just a moment, please. One of the biggest stumbling blocks to stillbirth prevention is its invisibility, which in turn limits investments into data quality and access. The global burden of disease has quantified morbidity and mortality for 30 years, helping to spotlight public health shortcomings and focus investment on the biggest gaps. In 2019, 5 million children died before their fifth birthday, of whom 1/4 were newborns. But in 30 years, the global burden of disease has not included stillbirths. If the 2 million stillbirths were included, this pie chart would look very different, with stillbirths comprising nearly 1/3 of deaths of children under 5. This word cloud from an analysis done for the Lancet's 2016 Stillbirth series demonstrates the challenges. Stillbirth is barely visible in this collection of the 500 most commonly used words in global reports on maternal and newborn health. As with stillbirth generally, parents who are bereaved by stillbirth are usually invisible. At most, it is parents' grief that might be acknowledged, rather than their expertise and their power. We've heard from Seema. Here are some other parents. Debbie says, "My heart shattered into a million tiny pieces as I lay there on the exam table." Sabine says, "I cried day and night." And Sophia says, "No one wanted to talk about a dead baby." I'm also a stillbirth mom. I clearly remember the sound of static instead of a heartbeat after the death of my first child, Wilder Daniel, after my perfect pregnancy. He was born at full term with no cause ever found. Oyele says, "Mothers should not be blamed." And Anne says, the stillbirth of her son began her quest for answers. Parents are not victims. They are stillbirth experts, and they can be allies in prevention. In 2016, the Lancet set out a call to action to end preventable stillbirths. I'll now share with you some observations on the state of the data related to some of these aims, along with what parents have to say about it. I hope that by the end of my presentation, through sharing the words of real parents whose babies were stillborn, I will have demonstrated the power of parents as experts in their own losses and needs, and as allies for the design, implementation, and review of interventions to end fatalism and stigma, improve quality of care, and increase research and audit to end deaths. Stigma greatly impedes progress on data for stillbirth prevention and bereavement support because it stops people from even talking about stillbirth, let alone investigating it and providing care for bereaved parents. The call to action aimed for all countries to identify at least one mechanism for the reduction of stigma associated with stillbirth, yet there is no data on this aim at the global level at all. In high-income settings, only 1 out of 6 surveyed countries has made progress. Yet stigma affected over half of 900 mothers in a recent study on stillbirth, and it's associated with other adverse outcomes such as poor mental health. Sabine says that hearing dehumanizing words from her neighbors was the worst. Lance calls for a way to support open discussion. Jill calls for raising awareness as a first step toward prevention. Chris says, "I want the world to know that talking to bereaved parents about their babies doesn't remind us that they died. We haven't forgotten." Priya adds, "I want the world to know and remember my son's name." Parents put a spotlight on the need to educate families and communities about stillbirth, to investigate and meet mental health care needs, and to give parents space to share their stories. Bereavement support is greatly needed for the millions of parents whose babies are stillborn, and its lack is intimately connected to the insufficiency of stillbirth data. The call to action aimed to ensure consensus on bereavement care at the global level, and while standards have been proposed, these are so far mainly informed by high-income settings and by health professionals, rather than by parents. And none of 6 surveyed high-income countries has their own guidelines, although there is substantial country-level evidence of some effective interventions, including seeing and holding babies and access to support groups. There is also great disparity in uptake across settings. Yet Priya says that talking about loss is sometimes all that is needed to prevent more serious mental health issues in the future. Lois highlights a workplace issue, sharing that her HR manager didn't allow her to take maternity leave as she had not born a living child. Sophia and Oyele call for more opportunities for therapy and sharing of experiences. Listening to parents highlights the need to track mental health care as well as policies that affect the economic costs of stillbirth, and to build up and ally with support organizations. Unfortunately, a study by the Stillbirth Advocacy Working Group finds that of more than 500 support organizations globally, fewer than 12% are from Africa or South Asia. Quality care is inaccessible to many women, and poor quality is a major contributor not only to stillbirths, but also to the bereavement burden after stillbirth occurs. The call to action set a goal of universal access to high quality care during pregnancy and birth. But while there are global standards for antepartum and intrapartum care, there are as yet no validated indicators for quality beyond quantitative tracking of skilled birth attendants and number of visits. Fewer than 2/3 of 90 high-burden countries have a quality improvement plan for maternal and newborn health, and quality tracking is also lagging in many high-income settings. For instance, 3 of 6 surveyed high-income countries had no data on access to early quality antenatal care in their most vulnerable groups. Lois tells a story that in her case, no doctor or midwife entered the room where she was laboring for 3 hours with her baby who had already died, not until her husband went to find the doctor. And even then, Louise's sister had to deliver her baby as the student nurse was afraid to. This is unfortunately a case study in the invisible quality of care data that may not be captured by existing indicators. Listening to parents highlights the need to break down barriers between parents and health providers during and after stillbirth. Education and training can play a huge role in improving data quality, and this could be more effective if done in consultation with parents. Research is, of course, what actually produces the data that we need to end stillbirths and provide appropriate bereavement care. The call to action aimed to increase country-specific stillbirth research agendas and perinatal death review, yet only about half of all 90 high-burden countries have made progress in these essential steps. The situation is similar in surveyed high-income countries. One consequence of data that is insufficient or isn't translated into practice is fatalism. This map from the Lancet's earlier stillbirth series shows that many health professionals agreed with the statement that a stillbirth is always or often a natural selection of a baby never supposed to live. Sophia recognized this fatalism in the comment from her doctor that her son's death was simply unexplainable. Sabine calls for gynecologists, midwives, and parents to be invited to work hand in hand with health researchers. And Debbie asks why investment in stillbirth research is not comparable to the burden it represents, 1/3 of deaths of children under 5. Listening to parents highlights the importance of perinatal audit and collaboration across disciplines, as well as parents' potential role as allies and partners in research. We know the burden of stillbirth is greatest among marginalized populations in all countries, yet this is one of the areas for which stillbirth data is most challenged. There is no global reporting at all on whether countries have even set subnational targets, let alone met them. This is also true in high-income settings. I'd like to tell you what parents have to say about this, but I can't. In high-income and low-income settings alike, marginalized parents are largely voiceless. In Ireland, where stillbirth rates in maternity units in the most deprived areas of the country are up to 3 times higher than in the least deprived areas. In Australia, where the risk of stillbirth among Aboriginal women is up to 50% higher than that of non-Aboriginal women. And in the US, where the stillbirth rate in Black families has been twice as high as the stillbirth rate in white families for 100 years. Here it is critical that subnational stillbirth burdens be targeted and tracked, and space be made for parent voices. This October, UNIGME launched their first regular stillbirth estimates with a webinar on Zoom. This high-level event was headlined by UNICEF and WHO leadership and included many experts. I'd like to end with some words from one of these experts, Christine Longaci, who is a 36-year-old accountant and mother of 2, an 11-year-old son, and a baby who was stillborn at 32 weeks last September. Christine says, it's alarming. Almost 2 million babies are lost every year. She says the reason she decided to speak up was to give courage to other mothers. She says we must break the taboo of stillbirth. We must empower these mothers. I hope that I have succeeded in demonstrating to you the power of parents as experts in their own losses and needs, and as partners in research and intervention through sharing their actual words. In the 21 years since my son Wilder was stillborn, at least 100 million mothers and fathers have suffered the stillbirths of their children. This is an incredible group with great potential for action, if parents are welcomed and recognized as experts and allies rather than as victims and afterthoughts. Thank you.
Thank you so much, Professor Susan, to bring out, the issues, the international perspective around stigma and mental health issues around the stillbirth, and also highlighting the need to hear the voices of parents for making a change or difference in this. And also thank you for being on time. All our speakers have been on time. Now I request Dr. Vivek Singh, who is our discussant for the evening, to take over the session. So before he takes over, let me introduce him. I have the honor. Dr. Vivek Singh is a health specialist working with UNICEF team supporting the Chief of Health in the effective management of UNICEF's health program in India. And he has 20 years of global experience working with the Public Health Department, academia, WHO, and UNICEF. He holds an adjunct faculty appointment at the Hubert Department of Global Health Rollins School of Public Health at Emory University. And Dr. Vivek is also an invited member of Indian Council of Medical Research Task Force on COVID-19 response. I invite Dr. Vivek Virendra Singh to kindly provide his perspective. Thank you so much.
Thank you, Sarita, for this introduction. Humbled and honored to be on this panel. Am I audible?
Yes, please.
So, very pertinent points have been raised by all the eminent speakers who've spoken, and also the experience sharing by Seema. From UNICEF, what I would like to highlight especially is from the recent release of the stillbirth estimates globally. And as the release report said, it actually is a neglected tragedy. And from a global perspective, as we also speak of India, and we have heard that in the last 2 decades, the annual rate of decline that we have seen in the mortality for children and also mothers and newborns, the same has not translated to stillbirth, and where we have seen that the annual rate of decline in the last 2 decades for stillbirths was 2.3% versus the higher annual rate of decline for the under 5 mortality. And why this is important, because again, I would pick up from one of the sentences from the previous speakers that this certainly is the most sensitive indicator for all the maternal and the birth care services that a mother gets. It remains the most sensitive indicator. And when we speak why, and today especially that we are discussing the data quality issues in terms of availability and the quality, why this becomes important, that let it be the most sensitive indicator for maternal and delivery services, is that this is the part which gets neglected, and is also we see that wherever we have this follows the same pattern for the maternal mortality and also for the newborn mortality for that matter. And if we are missing these numbers, then we would not reach the target of ending all preventable maternal and newborn deaths. Now, from the UNICEF perspective, especially for India, newborn mortality reduction with actions across the life course continuum from adolescent to pregnancy is one of the flagship result areas that we support the governments with, and that is where stillbirths becomes very important. And incidentally for India, India has set for itself more ambitious targets than the SDG goals of reduction to stillbirths below 12 per 100,000 live births. But India had set itself targets of single-digit stillbirth and newborn mortality reduction by 2030. And it has clearly articulated in the India Newborn Action Plan that as a country, we need to invest on information and data systems to understand the distribution wherever it is occurring and also the risk factors and causes for stillbirth. And that is one area within the India Newborn Action Plan which needs a greater investment. And this coming year particularly becomes very important for India to invest in improving the information and data system and knowledge around stillbirth if we have to meet the India Newborn Action Plan targets. Now, there are 2 or 3 very important points that have emerged from the discussion, and I would like to highlight that. And one of which is that if we try to see the pattern of where we have high maternal mortality and stillbirth, is also areas where we have weak health systems, and especially for skilled attendance around birth. And that is where, for a country like India, in this year which was dedicated to nursing and midwifery, where India is putting efforts to strengthen its midwifery cadre. So this is one area which will be very useful to ensure that we have the required human resource at the primary healthcare level for providing skilled attendance at birth. Another important point at this stage is the focus on quality of care around birth, because we know and we have seen from the data from the previous speakers that 50% of these are still happening during the intrapartum period. And that is where, continuing to focus on quality. So it's actually, if you see from the community perspective, it becomes as an accountability for the health system. If the mothers are showing up to a facility, then it becomes even more important to ensure quality care, so that increase in institutional deliveries, increase in skilled birth attendance translates into the prevention of maternal and newborn deaths, and including stillbirths. So focus on quality of care will also remain very important. Now, coming to the data side, and I'm especially referring to some of the issues that Seema raised, is where can we engage communities in improving data system? And that is where I think audits, the importance of not just recording, but also death audits becomes important. And this is where we can engage community, and India has a very strong network of the frontline functionaries who get engaged in some of these maternal and newborn death audits. So this is where we can make sure that some of the voices of communities get translated. I would also like to highlight another important point based on what I heard from Seema, is that it's also very important that while the parents are bereaved, the family is bereaved, that we maintain full confidentiality and also work against some of the stigma and taboos. So Seema highlighted some issues, and I would also further extend it, that also this confidentiality should extend to the healthcare workers. And there should be actions taken to reduce any punitive actions, even for healthcare workers who might want to improve services and their own actions for improving the experience of care of communities. And why I'm saying this is important is, this will then reduce the deliberate, if at all, omission or the inadvertent misclassification of stillbirths, and then they don't get counted. So this is also very important, that we maintain full confidentiality for the families as well as healthcare providers who with integrity are actually intending to improve services, but because of fear for some punitive actions, might not take actions which can improve our information for stillbirths. So this is an important point. And last but not the least, that for improving data quality, I think I heard from one of the previous speakers that we are working on the sentinel sites where we are using the ICD-PM classification. So this is where in-service, pre-service, and routine trainings, and as a country now we are embarking on the digital missions. So this is where the country's RCH portal is now being upgraded, and there are 5 states now that are going to pilot with support of WHO and UNICEF the maternal and child death surveillance system, which will now include information on stillbirths. So these are opportunities for country where all the stakeholders can converge to strengthen data and information systems for stillbirth in India. So that said, I would take it back to Sarita, please.
Thank you so much, Dr. Vivek, for talking about the measures that are in place for to meet the India's newborn action plan, and also the strategies around improving or reducing rather the stillbirths, and also to engage communities to improve the data quality around stillbirth. So it's been really good to hear about all this, the perspectives of different speakers around stillbirth, and the way the data quality can be improved, and the role of the community in improving not alone the data, but also the government to hear about and take action for this issue. We have we have questions from the audience. We may not be able to address all of them, but at least a few. So I'm just going to read, and just for the audience, even if we're not able to answer now, it will all be there on would be checked with the speakers, and we will get back to you. So there is one question. Thank you, Dr. Rakhi, for such an insightful presentation. You mentioned that 40% of stillbirths can be saved. What are the possible interventions, the demand and supply side, that you believe can make maximum impact, and when during the 1,000 days window? It's a question from Sahil Mahajan. Dr. Rakhi, may I request you?
Yeah, sure. Thank you for that question. So I think like many of the speakers said, and I indicated, that the time during labor and delivery is where the most intervention is required to save these intrapartum stillborn babies. As Dr. Vivek also highlighted, the quality during that time, what happens with the mother when the mother shows up at the facility, starting from how the labor is monitored, how the fetal movements are monitored, how the clinical decisions are taken as to when maybe a C-section is needed or not needed. So all the interventions that we know for neonatal mortality are exactly the same for stillbirths. It's not very different. It's just that how we intervene decides whether the baby is stillborn or is a newborn who dies later. So interventions are actually not very different. It's the quality of what you do between labor and delivery that matters.
Oh, okay. Sorry. There is a question, probably Suzanne can answer. I mean, in terms of, this is a very rare condition called postpartum psychosis. Does the chances of it increase if with stillbirth? Is there an emotional stress or something like that which is being addressed?
Thank you so much for the question. I'm not an expert in this area. However, I do know that there is an increased risk of depression and anxiety after stillbirth. Certainly not every mother or father experiences clinical depression or anxiety. There also is an increased risk of PTSD, but again, this is probably a minority of parents. I think the broader issue that Rakhi described at the beginning of grief is something that is applicable to almost 100% of parents. And while it may not proceed to a clinical phase, it's definitely on a continuum. And so there needs to be psychological support available for parents who want it.
Thank you so much for the response. So there are many questions, but I'm not sure because we're almost run out of time. Just one last comment, which by Tulsi Adhikari says that my heart goes to Seemaji. She has really sensitized me towards the pain a parent goes through after stillbirth. Everyone has the responsibility to work towards improving the situation. So with that, I think I thank all my panelists for such a wonderful discussion around such an important topic. And not alone that, improving and measuring an intervention, the steps to understanding where action is needed. And these, along with voices from parents and healthcare workers, experiences of stillbirth, can inform training, improve the provision of care, compel decision makers to pay due attention and respond to the problem of stillbirths. Over to you, Dr. Rajiv. can't hear you. Sorry, you need to unmute.
Yeah, sorry. Thank you, Sarita. Thank you, everybody, for joining this wonderful webinar, a different kind of webinar. And this time we tried, and I hope you liked it. I hope you are taking some messages back, some thoughts with you that how and why we should work on the stillbirth data. Thank you all the panelists, of course, Dr. Rakhi, with your passionate arrangements and passionate, talk today. Dr. Agarwal, Seema Zan, Dr. Sujana, and Dr. Vivek. And of course, thanks to our invisible support from Radhika and Trisha. And finally, so this was our last webinar of the year. Everyone have a wonderful rest of the year and a happy new year for 2021. And I hope to see you all in 2021 again. Bye bye.
Thank you.
Thank you.
Thank you. Thanks.